And now it's time for the sponsor perspective portion of our program. But before we get underway, a quick clarification. While this interview is being conducted by me and the questions are mine, this content shouldn't be considered editorial. With that, I'm joined by David Skorton, President and CEO of the Association of American Medical Colleges, and Karen Fisher, AAMC's Chief Policy Officer. It's great to see you both. David, you have a long history in this town. You've seen a lot. I should mention to our audience that you were the 13th Secretary of the Smithsonian, a great institution. Now you're helping other great institutions out in this nation deal with this. And part of what America does in times of stress is to step back and think what it needs to do. And you folks have put together a playbook on what you think we need to do in this crisis, and I'd love to hear your thoughts about that.
Well, it's a pleasure to work with you always, Steve, and thanks a lot for that terrific interview you did with the congressman and doctor. That was really terrific, and I just want to take 1 second to say that he was very eloquent in talking about the role of academic medicine and the potentially even greater role, and I very much appreciated that. Well, the AAMC, as some of the folks who are watching may or may not know, is a 140-plus-year-old nonpartisan organization that includes as our membership all of the accredited medical schools in the U.S., and for that matter in Canada, as well as about 400 teaching hospitals and health systems, and about 70 academic societies. And by the way, within that 400 hospitals and health systems are dozens of Veterans Affairs hospitals and medical centers as well. And so we're the only national organization that I'm aware of, Steve, that brings together those in the medical schools, the educators, the physicians, the researchers, along with the CEOs of the hospitals and health systems, along with those in academic societies. And so we brought together a lot of the thinking that we had learned from our members, along with things that we had learned from those who work at the AAMC. It came up with a list of 9 urgent things that need to be done in roadmap and 2 things that are longer-term actions. And because of the briefness of our interview, instead of ticking them all off, I'll just say that the 9 start off with supply and drug shortages, accessibility of testing, which you just had a terrific discussion with the congressman on, and national standards on face coverings. And then we go through a lot of other issues. So that's where we came up with it. And we think that one of the beauties of the United States of America is the distribution of responsibility, a lot of it to states and locales. But there does need to be some leadership from the federal level. And the idea of the roadmap was to take a national view and then indicate where there should be local prerogatives.
Well, one of the other things we've seen with this particular virus and the way that it is hit America is that those infection rates and I'm sad to say death rates in certain vulnerable communities of color, has been higher than others. And Karen, I know that you've looked at that and you've talked to lots of folks in the policy realm. You know, what are the sort of approaches that your members can take to help remedy and address that uneven hit from COVID?
Well, thank you for raising that, Steve. And that is one of the recommendations that we have in the roadmap, and that we just have to address the health inequities that really COVID laid bare. These are not issues that were new. Health inequities, health disparities have been around for a long time as a result of a lot of situations, but certainly we saw them highlighted in COVID, and we must address them related to COVID. You're going to hear probably from some of the panelists the disproportionate numbers of COVID patients in their institutions who they are treating in the vulnerable patient populations. We need to address the underlying issues related to health inequities, including issues around social and economic conditions, but even related specifically to COVID. You just talked to the congressman about testing. We need to make sure that vulnerable communities, communities of populations of color, ethnicity, need to get sufficient testing. We just endorsed a bill called the Motion Act, which would provide for mobile testing units that could more easily go into vulnerable communities to make sure they have the testing. We have broader issues around testing regarding funding, availability of the resources to ensure adequate testing. But for those populations that are being hit particularly hard by COVID, we must pay attention to that, Steve. And going forward, we need to collect better data to better understand what's happening with health inequities, health disparities. And when COVID is over, we can't stop there. we must look at the underlying causes.
I mean, I think that's such an important point, Karen, that you just made, because I worry about that. I mean, we've all been around enough to see, there's a lot of energy and muscle and motion and passion about this moment now. But when it's done, will we have the will? Will we have the political clarity and sense of purpose to address it? David, let me ask you, with your members, and something I've really been interested in, your members are sort of incredibly interesting institutions. They are research institutions, they're treatment institutions, and they're training institutions. They have all of these roles. Now, I know, my significant other is a professor in a university that's going online. I mean, everyone's been disrupted. So how has COVID hit these institutions? How have they swum through these challenges right now?
Well, I assume you're asking me about medical schools and hospitals,
yes.
although certainly higher education in general has been reeling from the changes that are occurring. But to focus on the medical institutions, we've really been hit, as you put it, in two ways. One is that in areas that are so-called hotspots, we've been called upon to do all of the frontline activities that we think about. Those activities related to seeing patients, developing protocols on the fly. We call this a novel coronavirus. We're learning really hour by hour, day by day, how to deal with it. And so a lot of that learning and sharing has been done by the member institutions. And in fact, one of Karen's and my colleague, Dr. Janice Orlowski, and her colleagues in the healthcare area of the AAMC have developed a terrific clinical repository where they have gathered the experience and the learnings of these member institutions. So that's number one, on the front line, taking care of patients. Also, as the congressman just indicated so eloquently, we've had the ability to work in a non-CLIA setting to set up a laboratory test that could very much and are very much helping the overall testing effort. And then thirdly, extremely important is the research environment, because we're going to work our way through this eventually due to scientific research, whether that research has to do with pharmaceuticals used for treatment of people who are already ill, or vaccines or other approaches. And a lot of that research is being done in the laboratories, in the institutions that we represent. So it's really quite broad, Steve.
Well, I think it's fascinating to listen to both of you. Another element of this that I discussed with the congressman, again, I was intrigued that it was in your roadmap, which I'd love for you to share with the public how they can find that roadmap. But when you talk about the national stockpile, I've talked to other CEOs of leading generic pharmaceutical manufacturers, leading regular pharmaceutical manufacturers, and they all argue about, we can identify, the top 100 or so drugs, therapies that we need, and we haven't approached that before. And I'm sort of interested, Karen, what does our national stockpile look like now, and what do we need it to be when it comes to medicines and therapies and other supplies?
Well, thanks, Steve. And David, I'm sure, has comments on that, too. It's obviously not been enough. And we've heard from our members since the beginning the ingenuity that they have experienced to try to deal with the issues surrounding the lack of supplies, whether it's been developing 3D swabs or 3D masks, et cetera, because there haven't been enough of those items going forward relating to drugs, et cetera. So we must figure this out going forward. And I'm proud of the frontline academic medical centers who have been trying to work beyond this. And I would say the congressman raised the issue of testing in the last segment and talk about academic medical centers. And what I would say is many of our academic medical centers want to do more testing in CLIA certified labs, but they lack reagents. They are not getting enough reagents. And these are centers that can turn around test results within hours. While other types of settings require multiple days to be able to do that. We need to leverage more the role that academic medical center labs can play with this pandemic. And I know all of our academic medical center labs want to do that. But certainly this issue surrounding supplies, we must do that. And I know David has some thoughts on that as well.
David?
Steve, thanks so much. Karen was eloquent and really hit a lot of the high spots. It's human nature, as you intimated earlier with a congressman, that, when the immediate crisis is over, we tend to go on to the next crisis and don't think about preventive things and sort of thinking toward the future. It's just the way we all are. Really, a lot of us are that way in our own lives and in our institutions. But my view of the strategic national stockpile is that it has two purposes. One is to amass supplies of things we know we're going to eventually need, no matter what kind of a virus or pandemic occurs, like things that will help us with ventilators and things like that we're going to need for anything that affects the respiratory system. But the harder one are things that come up along the way. So, for example, whatever new pharmaceuticals and vaccines come out of the enormous research, many of the research things are at our institutions, that will end up through this crisis. We can't even foresee now exactly what those things will be, but we will need to make sure that we put supplies of those things in the national stockpile. So things that are sort of evergreen, if you will, some of the things that Karen mentioned, supplies and things like that, and things that will come anew out of things that we learn within the pandemic. And that means the stockpile can't just be fixed in time. It has to be constantly reassessed and constantly refreshed. And by the way, those things that are put in there have to be looked at periodically to make sure that they are, up to snuff and still work. So it's a big, big job. And I hope we can all have the discipline to keep thinking about it, even when this crisis abates.
Well, I just want to thank you both, Karen Fisher and David Skorton. When you kind of look at this question, and because of you, I've gotten to know some of the heads of some of these other academic medical research centers. You have lots of different members. But, I'm a storyteller, and, when you do storytelling, most stories have heroes and villains. But in your story, you've got a lot of heroes. And I just want to say thank you for supporting today's program, and really thank you because I don't know if the public knows, when you look at treatment, you look at training, and you look to all the responses that are needed out there, is how much of the burden of this time falls on these institutions. So thank you so much for sharing these stories.
And Steve, thank you. And I want to thank you on all of our behalf, you and your colleagues, for bringing good information out that we sorely need right now. Thanks for doing these sessions. Thanks for doing what you do every day. And thanks for including us.
Not at all. Thank you.